Hello and welcome back again for today's second webinar. And thank you very much for those who join in for the second webinar again. And my name is Ayong. I am the Marketing and Educational Seminar Coordinator here at NeoBiotech. This is me right here. And today's agenda is to introduce our topic and the presenter, and also I will go over communication tools, and at the end I will make an announcement in regard to upcoming webinars and also watch previous webinars, and as well as how to receive your C credits. So please don't leave and stay until the end. And so today's topic is the simplifying grafting procedures through the use of the B.A.B.E, which is the biologically activated bone enhancements graft complex with Dr. Jason Kim. And here is some of the communication tools feature that we're to introduce. The first one, we are strongly recommended to use the chat box to communicate with me. And if you have any technical issues, and we will have a Q&A session at the end. So please submit your questions through this Q&A box right here. And Dr. Kim will answer your questions. So please submit it through here. And just one thing that I want to address is Dr. Kim may not answer all of your questions since we have a short period of time. So let's have Dr. Kim to start the webinar. Good afternoon or good evening in your time, Doctor.
Yes, Sayang, how are you? It's nice to be back, and thank you for the invitation and the opportunity to speak through this webinar. And
Always welcome.
I hope you and everybody is doing well. I know in California, I think they're starting to ease up some of the restrictions, I believe.
Yes, I am doing well. I hope all the doctors are doing well as well.
Good. Yeah. So, I mean, I'm in New York, and it's been quite an experience, and I do wish everybody safety and health during these times. And yeah, I'm hoping that we'll get through this soon. And I know we're all anxious to get back to our offices, treating patients, to even just gathering, socializing, going to restaurants. So just hang in there, be safe. That's most important. And know that we're in a good place. So I think it'll be good. So I just wish everybody the best. So yeah, with that, I'd like to thank you for joining us this evening. Some of you may have joined me this afternoon earlier when I had spoken a little bit about grafting and soft tissue protocols. For this presentation, I'd like to kind of go over what I call the B.A.B.E graft complex. And from the title, this is simplifying grafting procedures through the use of the B.A.B.E graft complex. And what that acronym stands for is the biologically activated bone enhancement graft complex, as Ayong had alluded to. Just to give you a little background about myself, I am in private practice. I have two offices. Well, I had two offices. I had one in Queens, one in Long Island with a partner. And I was teaching at NYU for a number of years, maybe almost 18 years or so. Then I decided to go back to school, actually, about 3 years ago to pursue my certificate in periodontics. And I'm hopeful, very hopeful, that in the next few days or weeks or so that we'll be able to complete our program and finally get certified and be official. So I'm very excited about that. And it's been quite a journey, to say the least, but one that's been very fulfilling for me, because I think with this training, it enables me to really be a better clinician. I've been able to see things from a different perspective. Coming from private practice background as a GP, it really opened my eyes in terms of how I can handle my cases differently, what I can do better, and how I'm seeing some of my older cases from a different perspective. So I am very grateful and appreciate it, and really enjoy what I'm doing. So with that, I'd like to begin the presentation. And again, the topic is really, how do we simplify grafting procedures? All of us, if you're involved with implant dentistry, grafting has to be part of your armamentarium. Meaning, if you're doing implant surgery, you have to understand how to do some grafting. And it could be as simple as basic socket grafting to advanced GBR cases. But we know how complicated and how difficult it can be in terms of making something work for the betterment of our patients. And we don't want to put our patients through surgeries, multiple surgeries, to try to come to a result. But sometimes we do, sometimes we have to. And so with today's presentation, I really want to focus on how do we simplify our procedures? What's out in the market today? What are people doing that's making their procedures a little bit easier, a little bit more less invasive, and maybe even cost effective? But what's ultimately going to be best results for our patients, giving us success, longevity, predictability. And so with that, platelet-rich fibrin, that's really been a pretty hot topic the last few years. And I was very fortunate enough to embrace this technology, learning from actually Dr. Jin Kim and his group out in California, from your neck of the woods, I am. But they really showed me and trained me how to use this technology, and I really appreciate what it does for my practice, and I appreciate what they've taught me. So, platelet-rich fibrin, what is it? A lot of you may have heard about platelet-rich plasma. So platelet-rich fibrin was actually first developed by Joseph Chacroun in 2001, and it's really a technique used to help accelerate and improve the healing of both hard and soft tissues. It's a very easy way of preparing our blood concentrates. So this is really the second generation blood concentrate, and compared to the previous PRP protocols, the expense is very minimal comparatively. So it's much easier, much more cost effective, and I think it's better for our patients today. So as I just mentioned, platelet-rich fibrin is a second generation platelet concentrate versus the first generation, which is a PRP or the PRGF, which a lot of us have heard of. And I've had my experience with PRP. When it first came out on the market, I embraced it. I incorporated it into my practice. But there were a few things that made it challenging. One was the blood draw. I had to call a phlebotomist, a nurse that would come to draw the blood for my patients, because I wasn't doing it at the time. And as a result, they always weren't that reliable, right, to say the least. So as a result, sometimes I couldn't perform the procedure on my patients, or the procedure had to be delayed for one reason or another. But understanding that the blood draw, if you get comfortable with that, then the procedure itself is very, very self-explanatory and very easy. So this first generation PRP platelet concentrate, the first generation really required the addition of some type of anticoagulant, whether it's bovine thrombin, calcium chloride, and it required a double centrifugation process, meaning you had to spin the whole cycle 2 times. So you had to go through a cycle of, say, 3-4 minutes in the centrifuge, stop the machine, take out, withdraw the part of the blood concentrate you needed, and then place it back into tubes, and then run the centrifugation again. So there was it was an involved process in terms of preparation and getting what you wanted in terms of the PRP. And it also had to require this addition of calcium chloride or bovine thrombin. And so the process itself was a little bit cumbersome. The cost materials of gathering your platelet concentrate was a bit expensive. It was, I believe at the time, $250 or $300. And so there's that cost factor that had to be considered as well. So the second generation, this PRF protocol, is much, much easier, much less armamentarium. So all you need is really what you see on the screen here. You see the vein puncture over here on the left, 21 gauge butterfly needle. You have your tubes to draw the blood, and then basically you just need your centrifuge. And this is the centrifuge that I've been using in my office for about 6-7 years now. And I want to say it's been a workhorse. I haven't had any problems with this. No maintenance issues. You can sterilize it, UV sterilize it internally with the press of a button. And so it makes it very, very simple. So the whole process of platelet-rich fibrin is in another way of terming this is obtaining concentrated growth factors. So you may hear that interchangeably, CGF, concentrated growth factors, or PRF, platelet-rich fibrin. So the benefits of CGF, platelet-rich fibrin, is that with this technique, with this protocol, it's a single spin centrifugation. We don't require any anticoagulants. There's no need for additional bovine thrombin and calcium chloride. And with the push of a button, it will bring it to a cycle of 12 minutes for this machine, and then it'll separate and fragment out the blood components that you're looking for. And so when we look at CGF was a study that it was just really another modified form of PRF. And that's been published by Masuki and his group in 2016. So it's really the same thing as PRF. It's just a modified form because of the different centrifugation protocol, meaning different speeds, different G-force, and so forth. But with this process, with this protocol, they're saying that you can get actually a much denser, stiffer, much more concentrated growth factor fibrin clot from this protocol. And so these are just an example of a membrane that we want to try and achieve. And the study's it's been reported in the literature. You have Andy Twelve with PRGF, Dohan and Shukron, those are the ones who really pioneered this PRF technology, Rodella studies in the early 2000s, mid 2000s. So the literature is abundant in terms of how to process and the benefits of what PRF and CGF does for our patients. And so Joseph Shukron, the pioneer, he's the one who really developed this technique. And we really want to credit him for, just really allowing us to be able to incorporate this new technology into our practice, so that way we can have more predictability, we can have longevity, we can have much more simplified procedure for our patients. And it really takes the stress level away from doing a surgical procedure. And as you all know, if you're doing these large surgery cases, it can be very stressful, right? So very tedious, very stressful. And then good friend, Dr. Mike Toffler, Paradigms from Manhattan, who's been embracing PRF technologies for a long time as well. So, I learned a lot from these pioneers, from these mentors, and I see what they do, how they treat their cases, how to incorporate this technology. So I'm very grateful. Dr. Son and his group in Korea, he's the one who really coined the term sticky bone. And, he does fantastic work. I mean, you have to see some of his cases that he does. So I've learned a lot from them. I've had the privilege of being able to work with him in some of these live surgery courses, and just be able to pick their brains and see how they do things differently. Really allows us to really take our practice to another level. Make us a better clinician. And so if you look at this picture here, the most difficult part of the procedure is this part right here, the blood draw. So this is really the most difficult part of the procedure. And if you can get comfortable with drawing blood, we're injecting patients every day. If you can get comfortable with drawing patients' blood, then you'll have no problem incorporating this technology. And so, most of the times we'll go to the patient's arm, the antecubital fossa. And as you see in this video here, the patient has a couple of good veins there, and they can be in the configuration of an M, or it can be in the configuration of a V, right? So everybody's a little bit different. But there are those patients who may be where you don't quite see the vein as clearly, or you can't really palpate the veins as distinctly. They do have tools on the market like a vein finder that enables you to use that light technology to locate where the veins are. Now you see I'm injecting the needle right into the patient's vein, and once you see that flash of blood into this initial part of the needle, your assistant will go ahead and insert the tubes to draw the blood. Now these tubes are negatively pressurized, so that way as you insert the tubes into the vacutator, it'll automatically just withdraw the blood into the tubes. And once the pressure equalizes, it will stop drawing blood, and then your assistant will switch out to the next tube. So depending on the procedure you're doing, depending on how many sites you're doing, if it's a 1-tooth site, 2-tooth site, or if it's a GBR or sinus surgery, then you could draw, however number of tubes you think you're going to be using. So I try to always kind of foreplan my procedure, meaning if I'm doing multiple extraction sockets, maybe 3 to 4 tubes is all I would need. For larger cases, GBR cases, maybe I'll need 6 tubes. And then I'll go through the differences between the tubes and how do we use each tube for what purpose. As you see in the video here, you have tubes that have red caps and tubes that have the yellow caps. The yellow cap, there's another one that's a white cap, and those can be used interchangeably. So the red cap tubes are the ones that are going to give us the dense fibrin clots. And those fibrin clots are what we're going to use to make our membranes. We can compress those to make membranes, and we can use those to make fibrin plugs, just whole plugs to place into, say, third molar extraction sockets. I do that routinely today for third molar extraction sockets, where I'll draw patients' blood. I'll collect and fabricate the PRF fibrin clots. Rather than compressing them, I'll just take the whole clots, and then I'll use those whole clots and pack that into the sockets. And as a result, I believe, and there have been some studies, I don't have the literature offhand, but cases of dry socket have been practically zero. So I haven't had any cases of dry socket, I want to say, in the last 6 years, to be quite honest. I don't even have the dry socket paste in my office. A number of years ago, you know, it had expired, and we threw it out, and I just never bothered to order it because these growth factors are in such high concentration, these fibrin clots, that it initiates the healing, it speeds up the healing, you get better healing, you know. So here's a video. That's the vein finder that you see on the right, right? In patients where it's a little bit more challenging to isolate the veins, you can use that vein finder. The middle video that you see are the fibrin clots that I'm drawing up. And these are the uncompressed forms of the fibrin clots. And those fibrin clots is what I just mentioned. Those are the ones I can pack directly into the sockets without compressing them. Or, as you see there, I can compress those to fabricate membranes. And then the third video on the right with the yellow cap that we just removed, we're going to withdraw the liquefaction of that separation. So that tube, the yellow cap tubes or the white cap tubes, will separate out the blood into two components. Whereas in the red cap tubes, the blood will separate into three components, which I'll briefly describe for you in a moment. But the yellow cap tubes or the white cap tubes, as you see here, the liquefaction, that's what we're going to use to hydrate the bone graft material. And whatever material you're using, whether it's, you know, allograft, xenograft, autogenous bone, you can use that liquefaction, the liquid phase CGF, some may call it, to hydrate those particulate graft material. After a few minutes, what's going to happen is it's going to start to hydrolyze and start to gelatinize and form like this putty-type complex. And that's where you get sticky bone. Some people call it staky bone. Some other clinicians call it a PRF block, right? So you'll see once we get through the brief intro, and you'll notice how we can make these things in the near future. I'll show you in a few minutes. So this is the yellow tube, the white cap tubes. These tubes are non-coated, plastic or glass, and these are used to draw the liquefaction of the separation. So this top yellow layer is the layer that we want to draw into a separate syringe so that we can use that liquid portion to hydrate our graft particulate material. And that's LPGF, the liquid phase CGF, or AFG, also known as autologous fibrin glue. Now these red cap tubes, these are coated on the inside. These tubes are coated, and that coating is what, as the spins in the centrifuge, will start to condense and form that dense fibrin clot that we're looking to make our membranes and our plugs with. So that's the CGF PRF layer. And the centrifugation cycle itself is a 12-minute cycle for this machine. It alternates speed, meaning it will spin, rotate at about, say, 2,700 RPMs for 2 minutes, bring it up to 3,000 RPMs for another 4 minutes, bringing it back down for another, say, 4 minutes at another lower speed. And so it'll alternate these speeds throughout the cycle process. We as a clinician don't have to do anything. We just push that button, the machine will take care of itself. Some of the other machines on the market are just a single spin centrifugation, meaning it's just a one spin cycle. So whether it's a 2,000 RPM, whatever you set it for, whatever you calibrate it for, is what it's going to spin at. And if you want to alternate the speeds, then you would have to manually adjust the machine settings so that it will spin at that respective speed. So, but with this process, it's a 12-minute cycle, alternating speeds. And Rodell in 2010 stated that by alternating the speeds, it allows the centrifugation to form a much larger, denser, and richer fibrin clot that has all these growth factors in a much higher concentration. And because it has such a high concentration of growth factors, that's what's going to stimulate and initiate and give better healing, faster healing for not just soft tissue, but hard tissue as well. And then this is the article, Masuki in 2016, where he compared several different models of centrifuges. And as you can see, the top three machines are single speed rotational centrifuge for X number of minutes. And whereas the metafuge, where we're getting CGF, you can see the alternating speeds. And it's a result of that alternating speeds at different levels that will give us a denser fibrin clot that's going to be better for ultimately our healing cases. And so when we draw the patient's blood, we will immediately, you don't want to wait too long. So you want to take those tubes of blood that you just drew and you want to put it into the centrifuge within a few minutes, within say 1 to 2 minutes. The whole draw process really shouldn't take much longer than 1 to 2 minutes. When you place it into the centrifuge, you want to make sure that you have an even number of tubes because the machine is calibrated and it has to be balanced. So if you have 4 tubes, you just want to evenly space them out within the centrifuge. If by chance you couldn't draw 4 tubes, you only have 3, then what you can do is you can take any tube and just balance it with some water, fill it with some water so that it has an even amount of liquid, and then just place it into the machine so that it's evenly distributed on either side. So you want to have an even number of tubes in the centrifuge itself. Now these are the 2 tubes. Remember I said it's a red cap tube or a white cap or yellow cap tube. And the centrifugation process, once it goes through the whole cycle, it'll separate out the blood into 3 components for the red cap tubes. The yellow cap, white cap tubes will separate out the blood into 2 components. And as you can see here, with the red cap tubes, you have the top platelet-poor plasma layer, the top layer up here. This is the layer that we want within the for the CGF PRF, right? This is the dense fibrin clot that we're looking to utilize. And then in the yellow cap or white cap tubes, this is the liquid fraction, the liquid portion that we want to draw up with a syringe. And then the red cell layer, that just gets discarded. We don't use that for any of our purposes. So it's really just this dense middle layer of the dense fibrin clot, the CGF PRF complex, and this liquid fraction of the autologous fibrin glue layer that we want to use. And so when we complete the centrifugation process, it'll beep, the machine will beep, we'll go to the centrifuge, we'll take the tubes out, and one by one, what we'll do is we'll take a college pliers and we'll just pick up the dense fibrin clots. And then what we want to do is we want to remove the bottom red cell layer. We don't have to completely remove all the red cells. You want to leave maybe a very thin layer of red cells connected to that fibrin clot, because actually that's where you have the most concentration of some of the growth factors. So you want to leave a thin layer of red cell layers connected to the dense fibrin clot. And once we complete that and when we cut off the red cell layer, what we'll do is we'll lay that into this presser. And this presser with the weight of the lid, what it will do after a few minutes, it will actually compress those dense fibrin clots to give us our membrane sheets. Now remember earlier I said if you don't want to use membranes and you wanted to use fibrin clots, you don't have to place those dense fibrin clots on this presser. Just put it separately into another container and then hold on to that until you're ready for your procedure. So in cases of where you're doing third molar extraction sockets, or if you're doing socket grafting, you don't want to use bone graft material, you can use just these dense fibrin clots, sinus surgeries, and so forth. So you can make membranes, you can have dense fibrin plugs to use for whichever procedure you're going to be utilizing. And then again, this is just the literature just showing you how with PRF we have a much denser fibrin layer that's giving us all the growth factors. And these are just some of the schematics that we've made from Rutgers describing the different layers within the components after centrifugation. So the dense fibrin clot layers where you have all the CD34 cells, the growth factors, the cytokines, which is what we want to use. And even within the white cap tubes, the yellow cap tubes, we want that liquid fraction to use that liquid layer. And it's because some of these growth factors, the PDGF, A.B.E factors, the TGF-betas, the VEGF, and the IGF, it's because these growth factors are in such a high concentration, that's what's going to upregulate and stimulate the healing process. You know, especially VEGF, that's going to upregulate the healing process, allowing us to have better soft tissue healing, allowing us to have better hard tissue healing, faster healing, and much more comfortable for the patients. So I think it's just a win-win for all of us, and something that I think we should all be embracing. And so now we're going to describe the formation. How do we make that bone, the B.A.B.E graft, or the biologically activated bone enhanced graft complex, also known as sticky bone, right? And so the picture you see on the left was particulate graft material. And if you know, and if you work with particulate graft material, basically it's just like sand, right? So it's just like sandy particles just moving around. And you know how difficult and challenging it can be when you're going to graft your surgical site, right? You place your graft material, blood gets into the site, and then what happens to your graft material? It starts to wash away, right? It starts to disperse itself, right? So then what happens? You got to go and get more graft material, right? Because a lot of it, maybe a third of it or a quarter of it had washed away in the blood, right? You lost some of it. But with this technique, with this graft complex, because of the fibrin, liquid fibrin component, the AFG, the autologous fibrin glue, what that will do is it will start to gelatinize and then compact and start to gelatinize and form this putty complex, as you see there. And that's Professor Son, Dr. Son, who I want to give credit to for really showing me and introducing me to this whole sticky bone idea. And so, but I just kind of renamed it myself, calling it a B.A.B.E graft, where I modified it just a little bit in terms of I'm using allograft, xenograft, as well as autogenous bone. So I can really get all the growth factors, so I can get the BMPs from the autogenous bone to really help improve the healing of our grafting procedures. Right, and so he published this article in 2015 with Dr. Jim Kim, as I mentioned, back in a few years ago. So before this, when I had initially started with this technique, I was using a 50-50 mix of allograft and xenograft. And together with the autologous fibrin glue, that's where I create my bone complex. But now with the B.A.B.E graft, I modified it just a little bit, where I'm using now 1/3, 1/3, 1/3. And most of the times, I can harvest autogenous bone. If some of you have seen my webinar earlier today, I'm using this like trephine core burr that I'm using to harvest autogenous bone. And by harvesting autogenous bone, I'm capable of using natural bone, autogenous bone. That way I can get the BMPs from there to mix in with the graft particulate complex. And so that way I can get some better regeneration for the site that I'm looking to graft. And so there's the liquefaction of the autologous fibrin glue. We're going to withdraw about maybe 1 to 2 mLs into a syringe. And with that, we're going to hydrate our graft, particulate graft material. And as you see in that well, that's being saturated with this fibrin liquid portion. And so again, I went from a 50-50 mix, right, allograft and xenograft, and then I changed it to now incorporating more autogenous bone. So I can incorporate some of the BMP from the autogenous bones to give me some better healing. And then after a few minutes, what you're going to start to see is it'll start to gelatinize. And then it'll have this kind of like sticky component because of the fibrin component of the liquid. And then now we have this putty, this complex that we can use and just bring it to the site to mold and shape. And if anything, it really makes the handling of our graft complex so much easier. We're not losing bone because it's getting washed away once it gets hydrated with blood. If anything, it's going to stay in that area. It doesn't move. And one of the primary requirements of grafting is that we have to have graft immobility, right? And so this allows it to have that immobility feature as well, because it's being held in place, contained, because of the fibrin glue that's held within from that liquefaction. So here's a little video showing you how we prepare our membranes, right? So here's the red tubes. And basically, I'm just going to draw the middle portion. I'm just going to withdraw that with college pliers, right? And then my assistant is just going to hold that in place while I remove that bottom red cell layer, right? And so you can see in the well, I have just a dense fibrin clots that's sitting in the well. And again, if you wanted to use some of these dense fibrin clots in the compressed forms, you just separate out a couple of those plugs into a different, either different well, different sterile cup, so that you could use for that extraction socket. So you can see I'm going ahead and just removing that bottom red cell layer. And depending on the procedures, if you're doing a larger augmentation, you would use more PRFs, maybe 4 tubes, maybe 4 membranes. If you have a larger site, multiple sites you need to fabricate more membranes, you can always go back and draw more blood from the patient, right? So, that's not a problem. So this doesn't always, we're not set in stone in terms of, when it has to be done or if it has to be done, right? So here I'm just kind of mixing my bone particulate material, so xenograft and allograft, right? So I'm just going to take a 50-50 mix. Now it's usually going to be a 1/3, 1/3, 1/3 mix. So I'm just going to mix that in, and then you can see the syringe over here where I already withdrew the liquid portion, the liquid phase CGF. So that's in the syringe in a liquid form, and you can't wait too long because what will happen, it'll start to clot, right? So you want to do this within a few minutes. Have your bone preparation, right? Bone graft, particulate graft preparation in place. Then you're going to go ahead and you're just going to use some of the liquid phase CGF to hydrate that bone. And I may need more. So that's why, depending on the procedure you're doing, you can draw 2 tubes, 3 tubes. Usually for sockets and some small ridge augmentations, 1 or 2 T site, maybe 1 tube with the white cap tubes is enough. If it's a little bit larger, maybe 2 to 3 cap tubes. And then there's the same thing with membranes. Many times I'm actually using more than 1 membrane for my procedures. even for sockets and single tooth extraction sites, I'd like to use probably at least 2 of those membranes. You know, it does break down in about 10 to 14 days. So I want to maximize the benefits. And here you can see now just how, well, sorry, you can see how after a few minutes, everything starts to gelatinized. And so that was once just particulate graft material. And you know what graft material looks like when when it's not in a compressed form like this, right? So that liquefaction will allow it to condense it. Now we have this little block, right? This putty complex that's loaded with growth factors. And so now we can use this, place it in the site that we're looking to graft, and we can stabilize it. And so it makes handling much, much easier. And so here's an example of just showing you of a grafted site where it was not loaded with PRF. Basically, this is just particulate graft material. And you can see, look at all the graft materials that's being displaced from whence it gets soaked with blood, right? So we're losing all this graft material. So in essence, if you really think about it, by using this technology, it really can be a little bit more cost effective because you're not losing and you're not wasting some of these particulate graft material. And so here's a case. Let's go through a couple of cases. Tooth number 31 is failing. You can see the fistula on the facial aspect. Proposed treatment plan was to extract the tooth. We'll graft it with our sticky bone, our B.A.B.E graft complex, and place a couple of membranes. We'll wait 3 months and then place implants and restore 3 months after that. So this is going to be a delayed staged approach where we're going to graft first and then come back to place our implant. So here's a socket. I apologize for the photograph, but had a buccal bone defect there. So we debrided the socket, we cleaned out, irrigated. We prepared our graft complex, our B.A.B.E graft or sticky bone. We took that graft, we packed it into the socket. Remember, it's also loaded with all the graft growth factors. And so that's going to allow us to stimulate and initiate the better healing. And then what you see over here in this photograph is a couple of PRF membranes that's laid over it. So it's acting as we were to use a collagen membrane. So in this case, in place of a collagen membrane, I'm using just a PRF membrane. And usually for small sockets, we don't have to use collagen membranes. Larger GBR cases, larger grafting cases where we may need a little bit more longer lasting membrane, then collagen membranes can be used in conjunction with the PRF membranes. So in this case, we're using PRF membrane without anything else, and we're not looking to get primary closure. Well, again, one of the benefits of doing simple sockets grafting is we don't need to get primary closure, and I'm not looking to get primary closure because I want to be able to develop a better soft tissue architect around that implant socket, that socket site. So B.A.B.E graft complex with our PRF membrane, placed a couple of sutures. There's no need for the primary sutures, and now look at this site. 3 months later, look at the soft tissue, look at the architecture of that ridge there. I mean, that's a beautiful ridge. I mean, that's what we look for. That's what we want. That's the type of predictability that we want to have. And some may argue, well, maybe you could have gotten the same results without any grafting. And I may have, but I think I would have gotten this probably a little sooner, right? It would have healed up a little bit quicker. But that's the other argument. You know, what's another couple weeks? What's another month of waiting, right? So depending on the clinical scenario, but I think just the added benefits of the handling capabilities of the bone graft material, speeding up, upregulating the healing process with your VEGF and your growth factors and so forth, I think it makes it much more a better tool and a better outcome. So nice, healthy keratinized tissue, right? Healthy gingiva, right? So with this case, we can either do this as a flapless approach, but I went ahead and I laid a flap because I wanted to see the bone. I wanted to see what's underneath, right? I want to see, did it really regenerate? You know, remember we had a buccal deficiency on the buccal wall. And so look at the ridge on this from this photograph. I mean, it's a nice healed ridge. I mean, I'll take that any day. And now with this, you can be sure that when you place your implant, you're going to have a nice implant in a proper position that's going to be well encased in bone circumferentially. And then we did this as a one-stage approach. And I made this comment, as you've seen in note, it says, implant was placed in 3 months, but I probably could have gotten in as soon as 2 months. That's how good the quality of bone felt when I went in. I mean, I can't really gauge it unless I did maybe ISQ test and a bone core biopsy to really evaluate the bone consistency. And I didn't do that for this case. I have a course for other cases, but it felt good in a way that I felt that I could have gone in and been my implant surgery in as soon as 2 months. So I think that's the benefit. I think that's how beneficial and advantageous this whole procedure could have been. And it was. So here's our CBCT radiograph, and you can see, right, from the radiograph, I wanted to overbuild, make sure to compensate for any resorption. You can see the loss of buccal plate that was on the facial. And then here's the final radiograph, right? Final CBC implant with final crown restoration. And then look at this. This is nice and well matured alveolar bone from that socket. All right, so nice implant crown. So this should heal and this should last a long, long time. So I want to take you through this case. This was a case that was done at another office. This patient was a friend of mine, and he had this procedure done at another dentist about a year ago, and he came to us for a second opinion. He wanted to evaluate, what his options were, because he was told that his case had to be redone. And so this implant was placed about a year ago. He went in for his routine recall visit. The dentist there told him that he had to redo it because of the bone loss, infection, and so forth. And so he wasn't really feeling too good about that. So he just wanted a second opinion. And so he came to us for a consultation. And so evaluating the area and looking at the implant, he had a case of periimplantitis, with some severe bone loss. And I told him that the best solution or ideal option for him at this point was probably to remove the implant and start all over, because it's only been a year, right? And really shouldn't have these types of bone loss within 1 year of implant restoration, right? Once it's been restored, to have it fail and lose this much bone within 1 year, something just wasn't right. And he was a healthy individual with no underlying complications, no parafunctional habits out of the ordinary. So, he was kind of unnerved in a way that, he wasn't really confident as to why this happened with the other dentist. So, and, whenever you have a case like this, I'm not going to badmouth the other clinician, but I just told him, sometimes these things happen. It could have been a failed root canal where maybe some of the bacteria may have been still dormant within the alveolar bone, right? That may have caused some of this infection. So there's a number of reasons why this may have occurred in terms of bone loss, periimplantitis, maybe implant design, implant placement. So we don't know all the information. So we're not going to really, quote unquote, badmouth the other clinicians. So all I can say is that, from my perspective and what I see now, I'm going to try and treat this as best as I can, that I think is going to give me the most predictable outcome. And he's a fairly young person, so I want something that's going to last 20, 30 years, right? So we want something that's going to give us longevity. And especially today in 2020, with all the better surfaces, the better grafting materials, better technology, there's no reason why we shouldn't have cases that last 20, 30 years, right? We should have that 96, 97, 98% success rate. So I felt the best option in his case was to remove the implant, graft it, place a new implant, and then go to restoration. And I felt the success of the case was really going to be when we graft this implant, when we remove the implant, that the grafting is going to dictate how successful we're going to be with this case. Because if we can't regenerate that bone, as you can see from the radiograph, with that large deficiency, if we can't regenerate that, then where's that implant going to be, right? We don't want that implant placed all the way down here where the bone is, right? Because then just think about the crown to implant length ratio, right? Think about hygiene. How's the patient going to clean with such a deep pocket, right? So I wanted something that I knew that was going to try and be as predictable to give them that long-term stability. So for this, I felt that if we can regenerate and rebuild that defect, that bone that's present, then I think we have a shot of having something that's going to last for a long time. So this is the clinical photographs. As you can see, the picture on the right, this, you can see, it just looks very, very angry, the tissue, right? Just a lot of inflammation, just very red erythematous. And so we knew that there was a lot of infection underneath. A little close-up view, soft tissue examination, right? So just not very healthy. So we would go ahead, we laid our flap, and you can see this was a 3.5 narrow diameter fixture placed for this premolar site. And I can only guess as to why a narrow diameter implant was placed. It looked as though the patient had bone, right? Because look at where the buccal plate is. Here's the buccal plate, and essentially, the patient had lost the whole lingual plate of this defect here. So there's the implant that was just backed out, and it really wasn't that difficult. So it just reverse torqued it out with this implant removal tool. We went ahead, we debrided the socket, really cleaned it out, and you can see the osteotomy site, right, the preparation. So essentially, if you looked at this defect, it's really a 3-wall defect, or some may say a 4-wall defect if you include the floor, right? If you include the base, we have a 4-wall defect. But essentially, we have the buccal wall, and we have our interproximal walls remaining. So we can go ahead, I feel, and do a traditional GBR procedure with bone graft and membranes to try and regenerate some of this lost bone. And which is what we did. So we went ahead, we wanted to initiate our grafting procedure. So we drew the patient's blood. We have our particulate graft complex, our B.A.B.E graft. This is at that time a 50-50 mix, allograft and xenograft, right? So here's our sticky bone, B.A.B.E graft, well hydrolyzed, well condensed with the growth factors. Now I pack it internally into the socket, and you can see how it's nice and well contained within the socket. But I also knew that I wanted to graft on the outside as well, right? Because remember, we saw that photograph of where we had a thin labia bone. Now that labia bone is going to probably resorb, right? We're going to lose that bone. And so to compensate for that and to account for any resorption, we're going to go ahead and we're going to graft on the facial as well. So when I do these cases, I'm not looking to graft just on the internal aspect. I found that over the years that I need to graft on the facial aspect as well, right? So that way I can maximize the amount of alveolar bone around the implants that's going to be placed. So we go ahead, we graft internally, graft the socket, we graft on the outside as well. And then we're going to use PRF membranes. So I have multiple layers of PRF. So these are compressed sheets of the fibrin clot. And so you can see I'm grafting on the outside as well, right? So you don't see any dispersal of any graft particles, right? So you can see how this is nice and well contained. So we have good containment, right? Graft immobility. And so we're going to use PRF membrane. Here's a PRF membrane that's going over from the buccal to the palatal. And I'm also going to lay a few more layers going on the facial, right? To cover the areas of the bone graft that we did on the facial, right? So multiple layers. And then for this case, I used a titanium reinforced dense PTFE membrane. So it's a non-resorbable, right? To account for not being able to get probably primary closure. Ideally, I would like to get primary closure, but I didn't want to risk having to hike the soft tissue all the way over, losing the vestibule, and then having to do another surgical soft tissue procedure later on. So I like using these titanium reinforced cytoplasm membranes. Today I'm doing things a little differently, where I'm actually going to fixate these in, a little bit more today. In the past, I wasn't fixating them as much. Some of the literature is showing that you don't really need to fixate them, especially the ones that are titanium reinforced. And so this one is titanium reinforced. You could get them from multiple companies, and then we got almost primary closure. So you can see from the CBCT, here's the CBCT. Now looking at this is all grafted complex. This is a thin buccal plate that was remaining, and then this is the outline of the titanium reinforced membrane, right? So on the facial, all I had to do was tuck it over on the facial, and because of the stiff nature of the membrane on the palatal, I felt that I could just tuck it in on the palatal. That way it will contain this graft material and not have to tack it or use pins for support. Another photograph of CBCT showing the grafted complex. And here's a 3D rendering showing the outline of the titanium membrane as well as the grafted area. And then about 4 months later, I was able to go ahead and place my implant. Now you can see we had pretty good maturation of that bone. So we got a nicely healed site where I was able to go and place a new fixture. And you can even see the outline of where the previous defect was. The outline right here. And this was all regenerated, this area here. So enough so that I can place my implant and do this as a one-stage approach. And here's the final implant. And we had done we had actually redid the crown for tooth number 14. And then here's the before, here's the after, and then after we took this photograph, we went ahead, redid the crown for number 14. Here's the before from the previous office, and then here's the final radiograph. And you can see how we were able to regenerate that defect from that periimplantitis case. I still am very cautious because periimplantitis, we don't really have a firm grasp of the etiology, right? Is it bacterial? Is it mechanical? Or is it a combination and so forth? right? But understanding that if we do and take the necessary steps, that we can minimize some of those complications. So he came back a few months later, no, actually about a year after we completed, recalls everything was fine. And then late last year, he came back. So the case has been restored and in function for about 4 years. What happened was that tooth number 14 actually started to fail. So this is now probably about 4 years. This was the before, here's the after. But you can see this is a radiograph showing you the regeneration and how much more denser it actually has become over time. So 14 started to fail, and so we removed the tooth. You can see from the CBCT, looks like he also had maybe a mucus retention cyst and so forth, but this was actually a good time to kind of evaluate the implant that I placed about 3-4 years ago using the whole PRF and B.A.B.E graft protocol, and how much I grafted, and was that graft maintained over the years. And this radiograph you see, CBCT, you can look at the amount of bone on the facial of that implant. So that held up very, very well. Look at that containment of the graft on the facial. And if you look at this picture here, this is direct mid-implant, right? The facial bone mid-implant, we have about 3.5 millimeters of bone on the facial of that implant. And that's phenomenal. That's what we want. And I can be sure that we're going to have good long-term stability for this implant as long as we have good, healthy tissue and it's being well maintained. And so that was just good verification of what we did 3-4 years ago and understanding how it was able to be supported and maintained over the years. So buccal ball, well maintained after 4 years. You know, we still have at least 3.5 millimeters of bone, if not maybe a little bit more. Okay, so here's the radiograph. You can see again, we can appreciate just the density of the bone after regeneration and repair. So this is the new implant that was placed inside of 14 with a little subcrustal bump. We placed an implant, and here's the final radiograph. And so this is now going on just under about a year or so, and 2 individual crowns. So when we did the implant crown for number 13, this was a PFM, and I was just starting to make that transition into zirconia, and this is our zirconia crown. So 2 individual units, nice, well maintained, and very supported. So here's another case, patient presented. Chief complaint was tooth number 8 has always been bothering her. It was endodontically treated years ago, but she understood that rather than retreating and going through restorative, she wanted that tooth out. And so her request was to remove number 8. She wanted an implant there, right? Because she heard about implants and so forth. But she was also missing tooth number 7. And so she wanted tooth number 7 built into the whole treatment plan. Tooth number 6, as a result of number 7 being missing, iatrogenically missing, tooth number 6 was actually built up with some composite. So she had presented with tooth number 7 missing, number 6 was built up with composite, number 8 was endodontically treated, that was failing. Clinical examination also revealed her midline was off, so she wanted to improve on that as well. So we had to go through several different consultations with her, giving her all the different options. And we had presented orthodontic treatment first, so we can move the teeth, so we can create some space between 6 and 8. So we could also shift the midline over, so we can have some better aesthetics with her her dentition. But she didn't want to go through the time of having braces or Invisalign, you know, for about a year and a half. And so she wanted, you know, something that was going to be quick, something that was going to be predictable, and something that she was going to give her aesthetics as well. So aesthetics was, I guess, really her main focus of what her desires were. And so the proposed treatment plan was to extract number 8. We were going to immediately place an implant in site number 8. We'll restore it with a provisional. We'll crown number 6. We're going to cantilever a pontic off of 7. We'll cantilever 7 off of 8, and then we'll veneer 9 and 10 and so forth. So here's our plan. Here's our CBCT of site number 8. You can see just a position of the root. And if you look at Joe Kahn's article with a sagittal root position, right, this is majority of cases look like this, where the root of the apex of the root is more facially inclined. So that means our implant placement, especially when we're doing immediate implant placement, really needs to be placed along the palatal wall so that we can engage more bone, so we can be within that bony housing. Right? So this is one of the challenges that we're faced with when we're doing immediate implant placements in the anterior aesthetic zone. So here's my osteotomy preparation. We removed the tooth, debrighted the socket. Here's my guide pin. Now, when I did the osteotomy preparation, I prepared it in such a way that I moved it as close to the midline as I can because I wanted to shift the midline. So we're trying to shift the patient's midline prosthetically. So rather than orthodontically, we're going to shift the midline prosthetically, and because we know we're going to do some veneers on 9 and 10 as well. So there's my implant preparation. Here's my implants placed within the socket. And again, I'm using nowadays a smaller diameter implant, 3.7, nothing larger than a 4.0 diameter implant, so that I can engage more bone, so I can have more bone within surrounding that implant in the anterior aesthetic zone. So then with the gap distance there, what I do is I'll graft the gap. So we'll graft it with our sticky bone, our B.A.B.E graft, right? So that way the bone graft particulate matter is going to be nicely well condensed within the socket. And then here's my PRF membrane. So I created like a poncho. It's a PRF poncho that we're going to see over my temporary abutment. So I have my implant fixture placed. I have my provisional abutment secured. I'm going to graft the gaps, right? If you look at Tornell's articles about the gap distance, he's saying if it's 2 millimeters left, we don't need to graft. 1.5 millimeters or less, we don't need to graft, which is true, right? Bone is going to regenerate. But for me, I feel more comfortable grafting those the gap spaces, because I want to make sure that I have more bone around that implant. If we don't graft that gap distance, there's always that risk and tendency of losing some volume because we're going to get collapse, right? So if we get collapse, even if it's say 0.5 millimeter, we're going from 2 millimeters to 1.5 millimeters, right? So then now, what are the studies showing? Look at Uli Grunder's study. He's saying you need to have at least a minimum 2 millimeters of bone, right? So Hohenbach's article, 2 millimeters of bone. So I want to make sure we have at least 2. I would feel comfortable with at least 3 millimeters of bone. So smaller diameter implant, graft the gap, and then make sure we have good soft tissue that's going to support that area. So PRF poncho, and then just a couple sutures just to hold that in place. And then I'm going to make a immediate provisional. Now this we can appreciate. Look at the CVCT, the cross-sectional CVCT. There's the buccal plate, and then there's the gap, right? And so I'm going to graft that gap distance, that gap space with some graft material. Because if we don't graft it, you can be sure that's going to collapse. We'll probably have some bone, but I want to make sure that I have bone there for years and years to come. Especially for a younger patient, I want to make sure that this implant stays in for 20, 30, 40 years, right? So that's what we're looking for. So I want to graft the gap. So I want at least a minimum of 3 millimeters of bone to be able to support that implant on the facial. That's going to support the aesthetics, because ultimately it's going to be regarding the aesthetics. So there's the B.A.B.E graft, grafted internally, graft the gap. Here's my PRF poncho, secured in place, and then provisional. We're going to use a non-functional provisional. We're going to use a shorter temporary crown. This one was actually cemented in place, and you can see how with the healing, right, the soft tissue is just starting to take shape. So we want to build in the emergence profile with the soft tissue architecture from the provisional. So you can see nice, well-healed soft tissue maturation. And with this patient, you can see nice, thick, healthy phenotype, biotype, right? Healthy, keratinized tissue. So here's the before, there's the after. So this is crown. This is a Pontic cantilevered off implant crown number 8. This is the veneer, veneer, veneer. I think I went as far back as the premolar for veneer. So I was only able to gain maybe about 1 millimeter in the midline shift, but aesthetically, I think this is a much more aesthetic result, giving her the needs that she wanted in terms of implant crown and then tooth number 7, because she wanted to have some balance aesthetically. So I think that turned out well. That's the final panoramic. Right, this is a case patient presented. She knew she had to fix her mouth. She had a broken down root tip in the posterior maxillary left quadrant. And so the treatment plan was that she needed to have a sinus augmentation procedure prior to implant placement. So here's an application for extraction of that residual root tip. We're going to perform our sinus augmentation. So we went ahead and prepared 8 tubes for our procedure. So 6 red tubes for PRF membranes and plugs. And because it's a sinus augmentation, I'm going to use 2 of the white cap or the yellow cap tubes for the liquid phase portion. And again, just same description that we showed earlier. So I'll go through this. We saw this earlier. But again, just showing you, so this is the dense fibrin plugs that we want, right? And if we're not going to compress all of them, we can set aside a few of those dense fibrin plugs for our sinus augmentation. Here's the liquid phase faction that we're going to draw, and we're going to use that to fabricate or incorporate that into our sticky bone. So here's our osteotomy window preparation. after we did our root tip extraction. Here's main membrane patency, right? Just showing you how the membrane is still viable and patent. There's no perforations at this stage, right? As the patient breathes in and out, we can see the movement of the Schneiderian membrane, right? If there was a perforation, we wouldn't really see that movement of the membrane, right? We would see a hissing sound or maybe a bubbling coming through that area. And so we know from the works of Rick Myron and Dr. Picos that they're using this PRF technology in sinus augmentations. And so I'm using this technology to be able to graft the sinus using particulate graft material, using allograft and xenograft, mixing it with the autologous fibrin glue, and making these bone blocks, these putty graft complexes, so that we can use that into the sinus. Right? So there's our PRF membranes. The video on the right, there's our graft complex. You can see we have this putty graft complex, right? That's now being held together because of the fibrin nature from the PRF, right? So that's got the growth factors loaded and embedded with it. But now look at the handling. I can handle this with such ease, and especially in the sinus area where one of the risks is blockage of the ostium because of the particulate matter. This material is not going to migrate. It's not going to move around. We're not going to lose that. It's not going to get into the ostium. So as long as we don't overgraft, right, we can be sure that this is not going to block the ostium. So just the handling capabilities is a benefit in itself. So this is the same procedure, same patient that I was just showing you. I did develop a perforation, right? And because of that perforation, we don't have to abort the procedure per se. So we can use either collagen membranes to seal the membrane. We could attempt to suture, right? Or worst case scenario, we can abort the procedure. But I like using the CGF, the PRF membranes. One, it's got all the growth factors that's going to help stimulate healing to regenerate the Schneiderian membrane. Two, it's got that fibrin texture, fibrin component to it. So what happens is, once we lay the fibrin membrane over the perforation, it's going to stick right onto the area, right? It's going to seal that perf. And this is what I'm doing here. So I'm elevating the rest of the membrane. You want to make sure with perforations that you can isolate the perforation. You're going to continue to elevate the rest of the membrane off the bone. And as long as you can isolate where the perforation is, now I have my fibrin sheets, my PRF membranes, right? And I'm going to use that, place it into the sinus where the perforation is. And that's because of the fibrin component, it's going to stick right to the fibrin, right to the Schneiderian membrane. So I'll use a couple of layers, right, so that I can get a nice seal. I've placed, I think, about 2 or 3 of the membranes. And as soon as I put it in, look what happens, right? See that membrane moving in and out? We got nice containment of that perforation. We sealed that up very nicely with the PRF membrane. So now I can go ahead and I can continue with my grafting procedure, right? So I can slice up my graft complex, and I can take those little plugs. I can take those little blocks of bone and just pack it into the sinus. And I'm not worried about this graft particulate material, dispersing and moving around within the sinus, especially in cases where we have a perforation, right? Because we have that fibrin component, because we had the platelet-rich fibrin that's embedded within the whole graft complex. And so now we have great containment of the graft complex, right? So we can repair that way. Here's immediate post-surgery. You can see the outline of the sinus cavity. There's the graft complex. If we weren't able to isolate the perforation and bone graft material got into the perf, what you would see an irregular kind of disbursement of graft material within the sinus, and that's where we can run into problems. So this is 1 month post-op, nice well-healed ridge, good soft tissue maturation, nice containment of the bone within the sinus. This is 6 months post-surgery. We've got nice healed ridge there. And if you saw my earlier presentation, I'm making my incision to the palatal so I can bring over the keratinized tissue. This is the easiest way to bring and maximize keratinized tissue. You want to apically position that flap. And look at the alveolar ridge, right? You can still see remnants of the graft particulate matter that still on the window area. And then we go ahead and place our implants. So 2 implant fixtures placed. We did this as a 1 stage because we had great stability. And for this patient, what I did was over here, we took a core biopsy because I wanted to measure the bone quality and bone quantity of that. And then we just kind of treated this as a 1 stage approach. And appreciating the amount of keratinized tissue that we can have on the facial of those implants. Here's a final panoramic. And, oh, I'm sorry, this case, because of COVID, she couldn't get the 2 crowns restored because of the whole COVID situation, but she's almost finished. But this case, you know, I'm confident that this is going to be a well completed case because we have good bony support, we have good fixture placement, we have good soft tissue support around those implants. This is a case, tooth number 19. I want to show you socket grafting, right? Look at the large defect on the mesial root of number 19. So large defect there with a fistula on the buccal. And this is a quick video. We were interviewing him because I had originally done a sinus augmentation procedure on him. For the sake of time, we're just asking him what his experience was, and he's explained to us how, you know, it was actually great that he had minimal swelling, minimal pain. You know, that whatever we need to do, if you want to draw his blood, that here, please go ahead, be my guest. So he was very willing to give us his blood, and you know, just because he appreciated just the benefits that he was able to have with the in terms of healing. So he was very comfortable, and that was the sinus lift procedure that we did on it. So for this case, it was a fractured root. You could see that, and it created a large defect there on the facial. I apologize for the photograph. And so we went ahead, same principles, same B.A.B.E graft complex, same PRF CGF membrane. Look at the bone graft complex that we made, right? And so we're going to go ahead, we're going to graft the socket, right? So just the handling capability, just to be able to bring and draw the material with such ease without it worrying about, you know, dispersing, you know, within the patient's mouth. So we'll pack that into the socket, you know, multiple layers, right? And then we'll go ahead and we'll take some membranes. I'm going to use multiple membranes for this procedure, laying them, you know, buccal to the lingual, laying them across the facial, right? We had lost the whole buccal plate there, almost about a third to halfway down, we lost the buccal plate. So we want to graft and regenerate that. So you can see here now I'm placing the PRF membranes, and then we're going to get closure. So I wasn't looking to get primary closure. And then this is post-graft. So there's, you can see, we're not getting primary closure, just multiple layers of the PRF. This is about 1 week post healing. And then here's the radiograph. You can see, you know, so a little bit immature, right? Still going through the healing process. You can see just, you know, how still inflamed it is. And then this is 5 months post-op. Look at this picture, 5 months post-op, right? I mean, with that type of large defect, the way that was healing, but look at the soft tissue. Look at that ridge there. I mean, you can do this now as a flapless approach. You can do this as a minimally invasive procedure, right? Something that's going to give the patient a very good result. And look at the bone. Now, I want to show you this, the bony architecture that we're able to achieve, right? Look at how much regeneration we're able to have all the way to the crest. And then place a single fixture, 1 stage because it had good primary stability. And then here's the before, final restoration restored, final restoration restored. All right, so he's in the process of getting his adjacent crowns redone by his local dentist. But we can see, right, just the amount of regeneration we're able to achieve around that socket, you know, even though he had that large defect there. This one, I think this is one of maybe the last case, right? This is a failing tooth number 7. Patient had presented again with some discomfort in 7. Clinical exam reveals purulence coming from 7 and 8. And upon probing, it was noted that number 8 was an implant. You can see the implant here, but I had probing. I was able to feel threads. So I knew I lost bone around those threads. Now this implant case was done by me. I had completed this implant case years back. And so whenever it's your own patient, you know what goes through your mind, right? So you want to do as much as you can to try and save and salvage your case, right? Because if it's anybody else, it's a failure, right? It's a failing case. That means, oh, those implants are coming out. But if it's your own case, you want to do whatever you can to try and maintain and try and salvage the case, which is what I was trying to do. So tooth number 7 had a periapical radiolucity, discomfort. There's bone loss around number 8. Proposed treatment plan was to remove number 7. We'll extract it. We'll immediately place an implant. We'll put a provisional on at the same time. And then we're also going to address the infection around the implant site number 8. The result of this infection was because of a fractured root. And so you can see, maybe a little difficult to see, a vertical fracture along the root of that tooth. And so we went ahead, we debrided the area, and now look at the implant. Look at what's going on. I lost that whole buccal plate around that implant, right? So even though it's maybe still only encased in maybe 2/3 of the bone, right? The whole facial bone was gone, right? So how am I going to treat this? Am I going to sacrifice this implant, sacrifice the prosthesis to try and get a new implant in? Or am I going to try and see if I can repair this? And now I want to say that today, 2020, we don't really have a predictable protocol of treating these peri-implantitis cases. So basically what I did was I just kind of threw the whole kitchen sink at this implant, meaning I try to treat it as best I can, try to disinfect it with whatever I had in the office. So I used acid etch, I used chlorhexidine, I used citric acid, I used mechanical debridement, Cavitron. I think I did a little implantoplasty as well to try and see if I can salvage this case to try and regenerate some of that bone. So, but I used the same principles, same B.A.B.E graft, same graft complex, PRF membranes, collagen membranes, and using that to graft the whole complex. So there's my graft, here's my closure, implant fixture placed. There's the CBCT, implant repair with new bone on the facial. And then this now is really going on 4 years post-op. But look at the soft tissue. I apologize for the, you can't really see that well, but I think one of the keys to doing these types of cases is really making sure you have good, healthy soft tissue biotype, thick phenotype. That's going to help you prolong these types of cases. And so this one, again, just really quickly, just showing sinus augmentation. We're winding up here. I'm using piezo for sinus augmentation. Here's my window preparation. We're going to place that window back on to the site after we do our membrane elevation, PRF. This one I use more of the PRF plugs, non-compressed form, right? Using that perforation, we seal the membrane. All right. Again, this one I showed you earlier. Pack the bone, graft, and then just place the replaceable bone and window back onto the sinus with a PRF membrane over that and closure. And so that's actually one of the best ways of getting osteoinduction. And that's from studies from Dr. Son and his group in Korea. And that's the final radiograph. You see where we had the perforation, bone graft, implant paste, and final restoration. One last case that may be non-implant related. This is how do we treat apicals. This was a young patient, female patient, about 27 years old at the time. You could see the large defect that presented. And so rather than condemning these teeth because she was so young, we said, let's try to salvage this and see if we can do some apicals and grafting, at least for now, because, we can always remove the teeth anytime if they do fail. So we decided to do some apicals, root canal treatment, same procedure, same protocol, B.A.B.E graft, right? We're going to graft the whole complex, PRF membrane, closure, and then this is the final CBCT, graft complex. You can see that. And so far, that's about 5-6 years old. And let me finish up. I'm sorry. Yep, I'll finish up with this one case. This is my own failed case where I try to be a hero. I try to do too much, right? So I try to sneak in this one implant and actually cause more of a problem, right? So what happened was I lost those two adjacent teeth. And so I had to wind up try to regenerate this graft. And look at this defect. I mean, this is a horrible defect, right? Just the amount of destruction that occurs, right? The vertical and horizontal. So I'm using titanium reinforced. I started with titanium mesh, but I decided to switch to a titanium reinforced because of closure, being not confident that I was going to get complete primary closure. So here's a Maryland bridge in place. 2 weeks post, you could see how the flap was breaking down. All right, so we went from this, now 4 months post-op, I think we were able to get some pretty decent regeneration. And this is all using the B.A.B.E graft, PRF membrane, B.A.B.E graft. Look at the soft tissue, look at the heel ridge. Not quite 100%, but still pretty good. And when we're dealing with the lower anterior, it's not really an aesthetic zone, but in any event, we're able to get some decent results. So there's the final radiograph. You can see regeneration of that defect. Panoramic, here's the before. This is what presented that I caused. And then here's the final restoration using a little bit of pink porcelain. So, this is showing you the benefits of what we can do to try to simplify some of our procedures. We're doing courses in terms of how to train you in how to use PRF, how to draw blood, how to incorporate this into your grafting procedures. And if this is something, that you want to start getting involved with, I encourage you, look for courses. But it really has been a game changer for my practice because of the benefits, the healing benefits for the patient, much more comfortable, much more easier for me as a clinician. So, if anything, I hope I was able to shed some light on some of the techniques and technologies that we're doing today, something that's going to help us benefit our cases for our patients, that's going to give us some long-term stable results, that's going to give us that success that we're looking for. And I think I had given you my email. If not, we can always get that out to you if you have any questions. I know to try and cover everything in an hour is not a lot of time, but hopefully this will be a little general overview of what you can do using some of this new technology. Thank you, and I do wish you all safety and health during this time. Thank you. I think we'll be open to questions now. Let's see, I can stop share. Okay. Okay, so, all right, so let's get to some of the questions. One question is, what do you charge for blood draw, centrifuge, and making the fibrin plugs? To be quite frank, I don't charge anything extra. I build it into the procedure. So I'm not charging anything extra to the patient. You can charge, and there are clinicians that do charge. It's built out as a biologics. But I explain the benefits to the patients, and I tell them that, we're doing this technology. I believe in this new way of grafting. I think it's better for the patient. I think it benefits both me, the clinician, and the patient long term. And so I don't really charge anything extra. And I just tell them, because I'm a big believer in it, and it doesn't really cost us a lot. I want to do this, so that way I can have better predictable results. So, but you can charge if you want, and you can charge a minimal fee if you like. So another question is, what brand of xenograft? I mean, I've used all the different types. So a lot of the graft materials I use today, I'm using from B.A.B.E. I've used. I'm using also the xenograft from Puros. So I use those interchangeably. But any xenograft material together in conjunction with some allograft material, right? So hope that answers your question. If you use a collagen membrane, would you use the PRF membrane adjacent to the bone graft and then collagen membrane? And yes, I do, and I have. And some clinicians, they do it the opposite. They'll lay collagen membrane over the bone graft, and then they'll lay the PRF over the collagen membrane, right? So the reason for doing that is they'll lay the PRF membrane over the collagen membrane because it'll be closer to the soft tissue. And because of the soft tissue benefits of healing, right, with PRF, they want the added benefits from the PRF to allow the soft tissue to heal better and faster. So you can do it that way. But you've seen, I've done cases where I've just used PRF membrane over the bone grafts. And so, but if you do that, you want to make sure you use, say, at least 2 layers of PRF membrane, right? And you want to also make sure that you have thick biotype, thick keratinized tissue if you're going to do that, because that's going to help stabilize and maintain closure of the graft. I really believe that. If you have a thinner biotype, you're going to be more prone to flap breakdown. So you want to use this PRF. Granted, it does have all the growth factors and it will stimulate healing, but you want to use this in conjunction, understanding that you want to have a better phenotype, better biotype with it. So, but I have used it alone, and I have used it with collagen membranes, and you can certainly do that. So do you charge the patient the same fee as a membrane? And so when I do my procedures, I charge them a fee. I don't charge them a la carte. I don't charge them separate for the fee for membranes. I don't charge them a separate fee for the bone graft. So I charge them for the procedure. And so if it's an augmentation procedure, for example, say it's $3,000, then I charge them $3,000, regardless of what materials I use, how much material I use. I just, that's all part of your initial diagnosis and treatment planning. How much you think you're going to need to graft to come up with the results that you think is going to be beneficial long term. And so I build in a global fee for that procedure, augmentation fee. So I'm not a la carting, each individual material per se. So I hope that answers your question. Okay. Next question, in case of number 13 failed implant before placing B.A.B.E. graft, did you score alveolar socket floor? Is it needed? And I did. So really going in with some sharp curettes to really debride the area. And some studies have shown that, even though you do that, you want to make sure you also want to irrigate the area, right? Some saline, maybe some chlorhexidine to disinfect the socket, the alveolar bone, because these microbes can leach into the alveolar housing, can leach into the alveolar socket. So you really want to make sure that you really debride the area, disinfect the area as much as you can. So I'm certainly going to keep them on antibiotics after the procedure, but I want to score the bone, right? So to be able to remove any granulation tissue. You also want to induce the RAP phenomenon, right? Stimulate some bleeding to the area to initiate the angiogenesis. So you want to scrape as much as you can. And yeah, definitely. Lastly, why did you splint number 8, 9 crowns and number 7 with cracked tooth? Which case? I'm trying to think of which case you're referring to. Why did I splint number 8 and 9 implant crowns and number 7 with cracked root? I can't recall which case that was. I'll come back to that later. If I can't answer it, you can email me, Jason Kim DDS, and then I can answer you individually. So if I don't get to that question. If you don't have my email, for all of you that are still on, my email is jasonkimdds@gmail.com. Very simple. So certainly reach out with any questions, comments. Always, looking to help out or even just go over cases. That's what we're here for. We want to learn from each other. And if I can learn something for you, that's how relationships are formed. So, I appreciate that. What speed and RPM used for centrifuge? So for this machine, I use the Silverdent machine. So this is the Metafuge centrifuge. And so everything's already pre-calibrated. Some of the other machines, you have to adjust the speed to say 3,000 RPM or 2,700 RPM. This machine is pre-built, pre-calibrated. So you don't need to adjust any settings. All you need to do is just push a button, push start, and then it'll go through the whole cycle. And I've had this machine for about 6 or 7 years now, and I haven't had one major flaw with this machine. Hasn't broken down. It's been a workhorse. So you don't need to adjust any speed settings for this machine for any protocol. Some of the other machines you can. You can adjust the speeds. And some of them are talking about slow speed concept where you're going to centrifuge for a certain number of minutes, right? Take out the tubes and then bring the speed down to 700, 800 minutes. Right, so those are different protocols. So there are a number of different protocols that you can follow, but the one that I showed today, you don't need to do anything besides just push the start button because everything's already pre-calibrated. After the B.A.B.E graft is prepared, how long can you wait to use it? So the sitting time, you have a couple hours before you can use the material. And even with the PRF membranes, you can let it sit for a number of hours. Some people have said about up to 6 hours. So any of these procedures really shouldn't be taking you 6 hours, but you do have time. It's just that initial working time where you're drawing the blood, getting it to the centrifuge. You want to do that as quickly as possible, right? Because you don't want the things to start to clot. So you want to get the blood into the centrifuge machine as quickly as possible. And then after everything's been prepared, you can use that and let that sit for a few hours. The only thing with the PRF membranes is if it sits too long, depending on the quality of the PRF clot, sometimes you may get a little shrinkage of that, right? So that's the only thing. When would you use large allograft particles? Thank you, awesome presentation. I appreciate it, Dr. Inga. So large particles I would use when I'm doing large augmentation procedures, sinus procedures. So, larger grafting procedures, I use larger particles. Sockets, I'm always using a smaller particle. So sockets, smaller ridge always is going to be a smaller particle. But if I have to use larger, it's going to be in cases where I'm doing larger GBR cases and in the sinuses, right? So that's where I use the larger particle procedure. In the anterior case you show with the titanium reinforced, did you have primary closure? So I did not get complete primary closure, which is why I think in that case I was using the cytoplast, because with the cytoplast, we don't have to get primary closure, right? So that's why I had changed originally from the titanium mesh to the titanium reinforced cytoplast because of the primary closure. So with the titanium reinforced cytoplast, it's not always absolutely necessary to get primary closure. That's why those membranes are used for. So when you place implant number 19, were you concerned about periapical radiolucency on number 20? I always am. And so we had to address that with the patient, but the source of infection at the time wasn't coming from 19. So it came from, it wasn't coming from 20, it came from 19. So we addressed that. And I think for now, so far, it's been holding up. So 20 really hasn't been an issue. Why do you think you have more chance of sinus perforation even though you use piezo? I don't know if you do have more chance of piezo perforation. Studies have shown that, it's supposed to be non-cutting. So that's why we use piezo, because it's not going to perforate the membrane. It just takes too long for me. So I don't think I said that it is more risk or more chance of using piezo, you get perforations. piezo, I've used it. It's a great tool, great instrument. It just takes too long, but it will minimize perforations. But again, nothing is 100%. So the more experience and the more you use of the piezo will definitely benefit you. So appreciate it.
All right, Dr. Kim, it looks like we answered all the questions.
Okay.
Yeah. Is there anything else you'd like to mention? And I
Uh,
think.
For me, no. I mean, it's always a pleasure and an honor for me to really present and share some of my experiences, because that's what it's about. It's really about sharing some of my experiences and what I've done, what I can do better. Always about learning. So, I commend you, everybody, from, taking time out of their days, and especially today's with everything going on with COVID, just these webinars are a great source of educating ourselves. So, I thank you, Neo Biotech, for the invitation. And for the
Always.
continue to just keep moving forward. We can never stop learning, and things are always getting better. So stay positive, stay hopeful, and also especially be safe and healthy. So thank you again.
Thank you, Dr. Kim, and for your presentation. And so, for those of you, if Dr. Kim did not answer all of your questions, he already mentioned about his email, so you can feel free to contact him that way. So now I just want to move on to the announcement a little bit. So if you are interested in taking our webinars, you can find upcoming webinars in our webpage here at www.neobiotechusa.com, and just simply click on this webinar at the top, then you'll be on our webinar page. And starting on next week, we will have two webinars every Monday and Thursday, so total 4 webinars weekly. And the time is 1 in the morning and 1 in the afternoon. I listed the time right here. And please don't be confused, it's a Pacific Coast time. and I just want to mention that all these courses are also on first come and first served basis. So please register in advance and reserve your spot. We also have a great lecture coming up on Thursday this week on Thursday, May 7th at 11 a.m. with Dr. Dennis Smiler on the Welcome to the World of Successful Implant Dentistry, and also on the same day at 2 p.m. with Dr. Spencer Park on implant stability. And also we have these more webinars. We can find it on our webinar page on Monday, May 11 and 11 o'clock with Dr. Ken Huang on sinus lip, and at 2 p.m. with Dr. Lara on implant complication and failure, and on Thursday at 11 with Dr. Owen Trin on anterior implant, and lastly on May 14 with Dr. Jeffrey Platt on advanced bone grafting. So this is for the next week webinars. Those 2 are Mondays and those 2 are on Thursdays. And these are more webinars that we added on our webpage. I will not go over all of these. You could find it on our website again at www.neobiotechusa.com. And here, now you can watch previous webinars on our webpage. So if you on our website, click on the previous webinars, and just be advised that we do not provide CE for watching recorded webinars, but feel free. It's all there. And I want to thank you again for those of you who stayed until the end. So one of our sales rep will email you the link to complete the course evaluation. So after you receive it, please fill it out and submit it as soon as possible so we can provide your CE. And also this form should no longer take 5 minutes to complete. It's very simple, and there should be, the form should be looks like this, and there should be more questions in the bottom. And I want to say thank you again for participating in today's webinar, and we really hope to see you again next time. So feel free to contact me if you have any further questions. Here's my email, ayong.chuy@neobiotechusa.com. And thank you again, and thank you, Dr. Kim, for your presentation, and also thank you all the doctors who joined this webinar this evening or this afternoon, depending on where you live, where you are. Yeah.
Thank you.
I do really wish you have a wonderful day.